Thank you. I wanted to begin today by telling you that I will be initiating Project 3 at the beginning of next week on Monday. It has a short creation project. Won't take you too long, and so I'm going to encourage you to try to get it done as quickly as you can so that we can finish out Project 3 by the end of the semester. I have posted the grades for Project 2. I know that there were a small group of you who had significant trouble posting your creation in Project 2, and I'm still considering that problem and how we might remediate it. But for the most part, Project 2 is finished, and the grade that you see is currently your grade on that project. For those of you who had that difficulty posting Project 2, I'll be emailing you over the weekend, okay? Meanwhile, in order for us to do Project 3, I'd like at least some of the class to volunteer to get some extra credit. Think that's possible? It'll be worth 1 percentage point of extra credit, but I need you to finish it by noon on Saturday, right? It's a small thing. And it has to do with our last topic, social psychology. Now, it should be posted here under extra credit, right? I'm going to show it to you in my view, but I will say very upsettingly, I was looking for it just 2 minutes ago in your view and couldn't see it. I'm not sure why. But if I look at our extra credit package, we now have this new quickie credit, basically. And this is what I always call this. This is like a quick extra credit that you can get about social psychology that asks you to use a well-known, famous app online called the IAT app that's produced and maintained by Harvard. And it's an app that allows you to run a little experiment on yourself in order to get a sense of what your inherent biases are towards certain objects, events, or people that we in general tend to carry stereotypes about. And so in this particular case, this is where you're going to find it. It's going to look like this. It opens today. Oh, this is my problem. No, it's due on the 22nd. I don't know. Oh, maybe this is the issue why you can't see it, because I changed the dates wrong. Do you mind if I correct that right now? What the heck? You can see it? Oh, excellent. I'm so happy to hear that. What day is today? The 19th? We'll make it due on the 22nd of this year. Oh, don't create anything. It doesn't like that due date. I'll fix it after class. But I did want to just show it to you. Yeah. So that you know what you're looking at. And you'll be able to, I'll fix this immediately after class. I've got the wrong date in there. But here are a set of instructions. Please read them. One of the most important instructions in the whole thing is very up here at the note. Make sure you look at the quiz you have to fill out before you start so that you fully understand what it is you're going to have to record while you're doing the experiment, so that you can do it while you're doing the experiment and not have to do it over again in order to get the material that we need, right? So make sure you look at the pseudo quiz, which is under quizzes here. This is what you'll have to fill out see, here it is, link to pseudo quiz. You'll open it and you'll look at the kind of questions you're going to be asked about your experience. There are 3. I'm going to ask you, what was the result you got on this particular question? What's the result you got on this question? And then look at this one. This is the one you all miss. I'm asking you to take a screenshot each time of your results and putting them here. Why is that? Because you are all lovely people. And I want you to get this credit. I do not want to give credit to people who just cheat. Okay? So please give me this information so I can verify that you were on the website, okay? And that you didn't just make it up because you heard it was an easy 1% point. I know that none of you would do that, but there are a few, okay? Yeah? Good? Great. And so what's interesting about this is when you go to the link for this test, right? You should open it from inside UB Learns and then go to the link in a new window and there'll be instructions. You should read these instructions. Because they're telling you that they allow this to be open to the general public, that some of the data may be used in an aggregate form, but there are literally millions of people that have done this, and so you will be a small little chunk. Many of those millions are doing it exactly for the same reason. Instructors use this all the time, and it'll show you all these different tests that it has. It has many. Oh, the ones that are really fun is the presidential ones. They're fun. They compare different presidents to each other, but I'm not going to ask you to do that. I'm going to ask you to do these two. This gender science IAT. And in general, in our society, people have a bias towards who is gifted and who is not gifted in the sciences. In the social sciences, this is generally gender or sex-oriented would be a better way for them to say it, where people view women as being less qualified for STEM jobs and men being more qualified. And this is just a general bias that we all have, right? And your generation should be less than my generation. They've been trying to work that out, but you'll take this and we'll see, right? And then the other one I'd like you to look at is disability, as again, we tend to hold a general bias towards people who are disabled versus people who are abled. And this is I want to tell you, we'll talk more about this next in the last week, but this is called an implicit attitude test. So your biases towards different groups of people or objects or attitudes that you have. Like maybe we all have an attitude that smoking pot is good, right? Or you might have the attitude that smoking pot is bad. Chances are your attitude is similar to your peer group attitudes. And you have hundreds of thousands of attitudes. Some of those attitudes actually would be termed prejudicial. And they're really specific types of attitudes that you hold that typically reflect the fact that you don't actually have very much information about that topic. You've had only a few experiences, and that there's a general social bias towards the group to begin with, right? And so those prejudicial attitudes are often of interest to psychologists to study and understand how they form and how we can get rid of them, or should we get rid of them. And, to say really quickly, attitudes and stereotypes are important survival skills for humans. It's one of the reasons we did so well in our evolution. But now in bigger societies, some things that worked really well for us, 200 years ago don't work so well for us now. And they get to have these reputations of being biased, et cetera, et cetera. So all this is doing is trying to figure out whether or not you carry those biases. But it does it in a tricky way. You have a question? Quickly? Well, pardon me? Our heuristic stereotypes. In some ways, a heuristic is like a stereotype. Not all stereotypes, though, are prejudicial. These are all prejudicial stereotypes, and stereotypes that are prejudicial have multiple characteristics that allow us to define them that way that we're going to talk about in week 15. For now, I just want to collect your unbiased data, meaning you haven't figured out how it all works yet, using this implicit test. And what's important here is this term implicit. It means that it's going to be trying to figure out your bias, the one that you're not consciously aware of, right? And I think it's really interesting. Psychologists have developed multiple implicit tests. This is an implicit attitude test. And it's trying to get at your attitudes, even if you would like to believe consciously you're not like that. It's trying to get at what you are sort of inherently underneath consciousness bias to, even though you may correct it completely every time you actually act, right? And so this is because it's implicit, meaning unconscious. And the method that they used is a common way in which psychologists get at these concepts of implicit. So I think it's a really interesting thing for you to try to see how they're collecting the data, how they manage the data. And I think that you'll be interested in finding out if you have any biases towards gender science or disability. Notice I haven't picked areas that are very contentious among your age group, because I don't really, at the end of the semester here, want to have a big contentious draw about prejudicial feelings. But you may be unhappy with what you get, but you should know that the minute you do this test, if you don't like the results, you will change them, and then you will be different, right? That one of the most effective ways to change a prejudicial idea is to make the person think about it a little bit. So keep that in mind, okay? And maybe you guys have no biases at all. That'd be great. I remember when I first did this, we just basically did men versus women. Who do you prefer, men versus women? And of course, everyone preferred men, and even me. I was even biased towards that way as well. And over the years, I check every now and then to see if my bias has somehow changed, and it hasn't. For whatever reason, implicitly, I always seem to have a bias towards a preference towards men and less of a preference towards women, which it just irritates me to no end, because I grew up in that era where women were supposed to support women and help women get ahead and that sort of thing. And I think if you look at my history, I have done all of that. The fact that I still have a bias probably more reflects the culture that I grew up in, basically. Okay, any questions? Please try to do this. It'd be fun if we can get a good amount of data. This is a big class. If you guys all do it, happy to give you that 1% boost. But in addition, it shouldn't take too long. Maybe 40 minutes max, right? Because you have to practice a little bit. Okay? And I hope you find it interesting. I think it's interesting, and then we'll talk. You'll have a project on it. You'll give me some feedback about what you think. I'm going to ask you to look at the data that we collected and compare it to the worldwide data. or a subset of the worldwide data, and talk about what are some of the differences you think that could account for differences between you and the rest of the world, essentially. Because there's always differences between college students and the rest of the world, thankfully, right? College students are different. And then next week, when we actually talk about attitudes, we'll talk about the data again, okay? And psychological disorders. Okay, in order for us to talk about psychological disorders, we have to at first identify what a psychological disorder is. In psychology, psychological disorders come in a variety of names. For example, they can be called psychopathology, it can be called abnormal behavior, or it can be called psychological disorders. The important thing for, I think, you to recognize is that we don't think of mental disorders as something different from normal behavior. In fact, a psychologist largely would say, look, we all have the same behavioral repertoires, right? We all have the same behaviors and mental processes, but they exist on a continuum. From at one end, we have balanced mental health, basically, or wellness, and at the other hand, we have unproductive, unhealthy mental health, right? And so psychopathology kind of falls at this other end, which would be mental health problems, right? Basically, same behaviors just now expressed in a way that is not productive for the individual. And so this is, of course, kind of the final settlement that psychology came to in terms of thinking about what do we mean by psychological disorders. We mean the abnormal expression of thoughts and behaviors, basically, is what we mean. Not that there are unique behaviors and thoughts that people have because they have a mental disorder, only that they are expressed in a different way. And so you might be thinking, well, wait a minute, I don't normally have hallucinations. The answer to that is yes, sometimes you do, just not at a very high frequency. For example, hallucinations occur regularly for all of us every evening when we sleep. We have a kind of hallucination that we call REM sleep. Everybody are familiar with having dreams, right? And interestingly enough, you can force those to become wakeful if you want. If you get enough sleep deprivation under enough stress, you can have a period of REM sleep as demonstrated by the precise changes in brain waves while you're awake. And when that happens, you experience a hallucination. Now, as that happens when people have psychotic breaks, have hallucinations, I don't think they know that yet if that's exactly the same as a REM sleep hallucination. It might be slightly different. But the point is that the capacity to have a hallucination is probably in all of us. It just doesn't happen frequently. There may be a reason it doesn't happen frequently. It may be blocked by something that individuals who have psychoses don't. Another time that we regularly have psychoses and hallucinations is when we use drugs like LSD, PCP, high doses of amphetamine or methamphetamine are really good at producing hallucinations. Evidence for that is always plentiful on Monday mornings at emergency rooms when the mental ward is full of people who came in with schizophrenic-like symptoms over the weekend, and so they were put into the mental health ward. On Monday morning, the doctors go through and see who's recovered, as that was more likely to be a drug-induced hallucination than a mental health-induced hallucination, and they let those people get to go home, essentially. And so the idea here is that we all experience all of these things just relatively at a different frequency or intensity, perhaps even. And so why is we talking about this so much? Because this was a huge problem for psychology, trying to figure out what normal behavior was. It was easy for all of us to kind of agree on abnormal behavior, for the most part, although there was a lot of discussion about abnormal behavior. What was more difficult was normal. And so sort of the list that you can't see, the slide that's missing today, which I'll post in my posted slides that I do each day, is a set of criterion by which we kind of talk about normal behavior. Normal behavior is behavior that allows us to be successful in society. Normal behavior is behavior that allows us to be successful in our relationships, successful at work, successful at school, for the most part. Normal behavior is behavior that is not necessarily, not frequent, not statistically rare, and not frequently statistically rare, among other things, right? In contrast, abnormal behavior, or behavior that we might say qualifies for a diagnosis of psychopathology, are behaviors that are allow you to be less successful at all those things. And two important aspects on that is that they are statistically rare. They are behaviors that one sees maybe 1 to 3% of the time, but in individuals that have poor mental health, they're occurring at a much higher frequency. In addition, to be qualified for poor mental health, currently people talk about the changes must be highly persistent, right? And when I was in school, and then really into the late 1990s, that what people meant by that is that they had to be symptoms, abnormal behaviors and thoughts that existed for a couple of months, or maybe even up to 6 months. However, in the late 1990s, the FDA allowed pharmaceutical companies to start advertising their drugs on TV, and pharmaceutical companies took it upon themselves to start telling people that 2 weeks of abnormal behavior was sufficient for you to go to your doctor and get a drug. And we say that all the time now. And interestingly enough, I just keep on waiting for psychology books to stop saying it, but they don't. Society kind of accepted that. And so now we do think that if you feel bad, or you feel different, or someone tells you you're behaving badly for a couple of weeks, that maybe that's time to go see a professional. I think that that's a highly debated point, and I think any psychiatrist or psychologist would probably see you, right, but would be kind of waiting for quite a while before they would actually consider that a psychological disorder. Yep. Oh, what do I think? Oh, I think it's probably a couple of months. But that's how I was trained, and that's how I've thought about it for years and years. They usually say more of periods of months. They don't really say anymore. They say kind of periods of months as opposed to days. So I think some of this is sort of socio-cultural or maybe socio-political at some level, how much. But I think the most important cue is it can't be a one-off. It can't be you had a bad day. It can't be that you had a couple of bad days. It has to be something that's dragging you down. Notably, it has to disrupt your relationships. Typically, relationships are quite tolerant for some period of time, right? It has to be disrupting your work sufficiently that you're now in jeopardy of some sort. And yeah, you can have one bad day and lose your job. That does happen in the real world, but it doesn't happen very often, right? And you'd have to have like a really seriously bad day, and it would be problematic. And so I think that, again, you have to have the combination of these things. You can't be persistently sad, because in college, everybody is sad. So it's not rare enough to some extent. Your sadness would have to be very deep and different than everybody else's sadness. Do you see what I'm saying? So that can even be persistent. It can't be the case that you're sad from September to December, but somehow on December 15th, everything gets better. You've taken your last exam and life is good, right? That's debatable as to whether that's really abnormal behavior. Okay, so there's some things to keep in mind. Keep in mind the notion of it has to be persistent. Keep in mind it has to be statistically rare. And then the very last thing is that we consider it a mental disorder if the individual feels distressed. So if an individual comes to you and says, I am distressed, I have been distressed for a persistent amount of time, even if there's not statistical rarity, they would still treat that and consider it a mental disorder, right? Because it's sort of like there's two sides. There's society can determine if it's a mental disorder, and then you as an individual can determine if it's a mental disorder, and you will get treated in that extent, okay? And so the other slide that we're missing is a slide that defines a few words. And so I'm going to just post that slide for you to look at. They're also in your book. And it talks a little bit about the incidence of disorders in the United States. I have other slides to cover that a little bit later on. So I will include those 2 slides at the beginning of my packet that I post, and we'll move forward. I will tell you, though, in the United States, substance use disorder or substance use and abuse, so let me just say it again, a substance abuse, which can include substance use disorder, is considered the most prevalent disorder in the United States. That would be because of your age group. And following that is depression and anxiety. Worldwide, depression is the most common mental disorder, so a little bit different than some of the highly westernized countries, which tend to have substance abuse up there. And I think that's sort of an interesting thing to think about. Okay, and so we'll get back to those numbers about how frequent things are a little bit later in the talk. Okay. So psychologists are interested in doing a variety of different things. They want to first of all be able to diagnose. This is like a huge area of research in psychology. How do we diagnose the different mental disorders? The second thing is that they want to know how to identify the causes of those disorders. They want to understand what the prognosis is going to be, right? The prognosis is, how is this going to play out? When will it be over? What can we hope for recovery? Most mental disorders are cyclic in nature, right? So they do come and go. So this prognosis is sort of an estimate of how it's going to go for the rest of your life. And then finally, they want to be able to treat it, right? And so today, in the next class, we're going to talk about the first three things: diagnosing it, identifying its cause, and then identifying its prognosis. And one of the kind of interesting things is that in clinical psychology, so all this is relative to clinical psychology specifically, people take very different views on how, or have taken historically, very different views on how to approach the problem of the cause that really reflects their sort of bias or perspective on psychology. So for example, biologists, biopsychologists see that abnormal behavior and abnormal mental thoughts must be related to some change in the action of genes, hormones, or neurons and neural circuit information, right? And so they would look for the problem, the cause of depression, the cause of substance use and abuse, the cause of anxiety in a change in the activity of some neural circuit. They have only identified one neural circuit so far in that regard with any confidence, and that relates to schizophrenia. Schizophrenia is one of the mental disorders that falls under this, clearly under the guise of mental disorders, but it's not one that's been studied heavily by psychology because it was considered an organic disorder, because there was easily, even 50 years ago, there were easily identified changes in the brain structure in individuals who had schizophrenia. And so this made it fall into the medical field. And so psychology has only recently begun studying schizophrenia again, because after 50 years, they still don't have satisfactory treatment for schizophrenia. And so now they're trying to integrate it back into some psychology strategies. But it is clear that individuals with schizophrenia do have substantial changes in a particular neural circuit, and perhaps several neural circuits that seem, the empirical data would suggest, may explain many of the symptoms, or at least the symptoms of schizophrenia. Psychodynamicists, so the people coming out of Freud, who was the first clinical psychologist, right? They see all these mental disorders as a conflict that's happening to the ego. So the ego is failing, and so you have this conflict between the id and the superego that is producing bizarre behaviors, essentially. And alternatively, Freud would argue it may happen during development and then become a persistent personality type disorder. But other than that, it can be any day, any time of year, just some failure of your ego, essentially. And Freud admittedly said that his theories about the mind only related to things like not obviously organic problems. So he didn't include psychosis or schizophrenia in his understanding of mental disorders. He saw those more as neurological disorders, which we would not do today. There's also clinical psychologists who consider themselves humanists. These are the positive psychologists these days. And they, of course, are similar to the psychodynamic theory. They see that, except they don't see that there's a conflict between the id and the superego. Instead, they say, you're born with some potential and you don't know what that potential is, but you strive towards it. And if you have an inconsistency between what your natural potential would be and what you're actually achieving, this will create bizarre behaviors and unsatisfactory behaviors and a great deal of undesirability of yourself, basically. So these often humanists see potentially people who see themselves as having massive distress, not necessarily the people around them seeing you have massive distress. And more currently, psychology in general tends to fall towards this cognitive behavioral perspective, which thinks that it's learning predominantly that leads to maladaptive behaviors and thinking. That in learning, of course, requires you to create many associations with environmental stimuli, to have the proper perceptions and reasoning skills. And so cognitive behavioral therapy tries to improve these things in order to reduce maladaptive behaviors and mental thinking. There's also clinical psychologists who take a view of sociocultural view. These are also sometimes called system psychologists. And they feel like people who experience mental disorders are reflecting the inappropriate system in which they live, right? And so there was a famous movie, I don't know if you guys watched anymore, long time ago, called What's Eating Gilbert Grape? I think it's something they like to show in secondary school someplace. Anyways, it shows an adolescent who's having mental disorder problems like depression and anxiety, But when you look at his family's got one sister who's failing out of society, a mother who can't leave her chair in the living room because she's allowed herself to gain so much weight, and a variety of other things in his life that contribute to the difficulties of his life. And while his family is expressing behavior in kind of a normal way to some extent, he is not, because he's reflecting their difficulties. And then finally, there's evolutionary perspective, which suggests that all of our maladaptive behaviors are, in fact, behaviors that were successful at some point historically or in our evolution, and are no longer successful given how our cultures and society have changed. There aren't a lot of theories from this group, but right now they are suggesting that this is the case for ADHD, that ADHD is a set of behaviors that we now consider abnormal to some extent, but in fact were very successful maybe 200 years ago, and these were the people that were most successful in society at that point. But because society has gotten more multitask-oriented and more dense, this disrupts the successfulness of that set of behaviors. And so evolutionary psychologists have to see that we inherit our behaviors. They don't see them as flexible as learning and things like that. And then they apply this idea that it must have been good for us at some time. Any questions? Did you have a question? Nope. Oh, yeah, okay.
For the example that you are you implying that the issues within himself were a result of implying like his mom?
You mean, the systems? You're talking about the sociocultural system? Yeah, like, well, I mean, I think that this group, I'm going to simplify this a little bit, but can you imagine that you find yourself one day in a social situation that's very odd, right? But you're there, you're trying to make it through, and you notice that even you are now exhibiting odd behaviors in order to adapt to your situation. You're being adaptive. And systems psychologists will argue that, in fact, there's some major problem in the family unit or in the subculture where you're living, and you have adapted behaviors to address that. But those behaviors are not successful for you in the larger community, and are not, and so you're feeling depressed because everyone around you is having a hard time, right? You yourself are not depressed. What's happening to you is not making you depressed, but it's that your mother is ill, or your father is ill, or your brothers and sisters are in jail, or doing drugs, or are suicidal. So you're sort of reflecting the people around you, and your mental disorder is a reflection of the disorder that's happening in your environment. It's not as popular a view these days, but during the 80s and 90s, it was a very popular view. Yeah. Yeah, this is the leading strategy for therapy right now, and we'll talk about therapy probably on Monday. Okay, so does that make sense to everybody? So if you find yourself a psychologist, you might ask them, what kind of psychologist are you, right? Like, what is your perspective about psychology? If you did that today, chances are this is the answer you would get. They would say, oh, I take a biopsychosocial view, which basically means that they see the problem as probably an interaction between biological factors, cognitive factors, behavioral factors, and sociocultural factors. In other words, I don't know, probably everything, right? No. And this is, while cognitive behavioral therapy is the most prominent therapy you see these days, this is most people's views. And, we don't do it now, but it used to be the case that anytime you went to a psychologist or psychiatrist, they would send you away immediately to go to a doctor to get a full physical so that they could rule out any biological origin. Like, for example, in women of your age, for example, up until about 35, you often find a high degree of depression, and that depression can be linked directly almost to a good number of people to iron deficiencies that are very common in women in that age. And if you fix the iron deficiency, voila, the depression goes away, right? So, physicians, they don't do it so much anymore, but there is this underlying acknowledgement of the fact is if they start treating you, they assume you have no major biological problem, and that's been ruled out that could cause those issues. In older Americans, depression and anxiety are often secondary to type 2 diabetes, right? And other metabolic disorders. Or if you have a cardiovascular problem, you don't know it, this will also change your mood dramatically. We now even think that the kinds of foods you eat can modify your mood. And for some people, that does indeed induce something that is so persistent that they seek out help to understand it. So we don't quite understand how these things are related yet, but we know that there is some relationship to them. Yeah?
I was reading some studies that
Yeah.
That's crazy.
Why? What happens when you're depressed? What do you do? What's the behavior of a depressed person?
Yes, it makes so much sense. It was a doctor, he was describing that he went to the dentist and he had a lot of work done and he was in pain and complained.
Yeah.
And within 48 hours, he was exhibiting symptoms of depression.
Yeah. But we wouldn't call it depression because it's not lasting long enough, right?
Right.
Mhm.
But that's how they got the idea that inflammation and
Yeah.
depression, like organic and psychological.
Yeah, no, there is considerable evidence in support of that for people that have things like rheumatoid arthritis, where they have constant inflammation, and there are some recent changes to all of our environments that support greater inflammatory responses all the time that people now speculate may be at the basis of increasing rates of anxiety and depression. But the fact that the immune system can cause depression shouldn't surprise you, because what's the immune system's job? It needs to get you to rest. It needs you to slow down, don't get excited, and stay quiet, right? So the fact that it does that, can work on the nervous system, isn't surprising that it can do that, right? Makes sense? Yeah. But it's also, so like some of the concern they have about foods, like, you know, we have that guy now, Kennedy, right? And he makes lots of claims. His claims are not necessarily wrong. How you correct it doesn't make a lot of sense to me, but he's brought up this idea that we have these dyes in our foods. And in addition, processed foods do induce a pretty robust immune response to the whole body, right? And so we might be all running around all the time with a much higher immune sensitivity than we really need to have in our environment. Just something to think about, right? Yeah, so he's not wrong about that. Whether or not that's more important than the amount of lead that's in our water, I'm not sure, right? Lead makes you not so smart really quickly. So I don't know. All right, so so we can talk about some of these things. Yeah, I'm just having a technical day. Can I just shut the whole thing off? Yeah, so it gave me like an AI thing. Is there a problem? Yeah, go away. Yeah, so anyways, most of us are instructional in that way. So I'm going to show you, at the next class, I'll show you a list of all the different symptoms, but I thought we'd start out by talking about anxiety disorders, and this is just as good a place for us to finish out the class as any, given the day. And before we start, I got to stop. So there is a really famous mental disorder that's called that you find largely among 101 students and medical students. And this is a disorder that is characterized by a large number of symptoms that relate to almost every psychological disorder. It's real. People seek out treatment for it. But it's also something that disappears almost immediately as soon as they stop studying the topic. And so it's really easy to see yourself while you're looking through all of these symptoms, right? All of the psychological disorders are defined by the symptoms they create. Remember what I said, we all express all of those symptoms, just not frequently. And so you can find those symptoms in yourself all the time. Don't do it, right? You probably don't have those symptoms. I mean, you might. Anxiety and depression in college students is on the rise, and so you might have some of this, but it's not likely that you have schizophrenia or manic depression or bipolar disorder or you're hallucinating all over the place. These are not common things. You don't have split personality. We just don't see it in a high enough frequency in your population for you to worry about any of that. Yes?
This might not be helpful for the conversation you're having right now, but how impactful do you think the placebo effect is on developing action?
Symptoms? Oh, so almost all of the diseases, even, including all of the mental disorders, typically can generate a pretty good placebo effect in their treatment. Like you can make suggestions. So again, what I'm saying is that you can suggest to people, like try not to label people. You can suggest it to them and then they'll become it, right? And of course that happens for thought-related disorders and things. And because again, mental health is on a continuum. Most of the time you're sliding around that continuum. You might have a bad day, but then you come back and we still wouldn't call that abnormal, right? So keep that in mind as you read this material. It's unlikely that any of you have a particular mental disorder. If you do, you can ask me about it and I can send you to some place that can check that out, right? So just so you know, you can always come and talk to me about it. I can't say no. But I can't diagnose you for sure. I can't do that. But I do know many people on campus that could, and we can get you into something that'll make you feel better. So, because if you're feeling massive anxiety and those sorts of things, you should check it out. You know, the Life Center has coaches also for that purpose.
Where do you think like your informational understanding of the topic comes out of shortfall for diagnosis?
Oh, so he's asking about diagnosis. Diagnosis is tough. Why? Because it's based on symptoms. Does anybody know the name of the symptom manual that we all use to diagnose? Oh, I wouldn't use it, but a clinician would use it. Yep, right, DSM-5. Good job. That'll be on the exam. Well, right now it's TR. I won't put TR into it, but yes, they keep on updating it every couple of years, and it gets a slightly different ending. But it was last updated in 2013, and the DSM-5 goes hand in hand with another one that all the medical doctors use. Anybody know the name of that? It's right now called the International CD, ICD-11, I believe. The International Diagnostic Manual. You've seen your doctor use it. And it diagnoses all diseases, including mental disorders, by symptoms. This is what these two manuals do. They diagnose by symptoms. And this is the best way we know how to do things. And the manuals exist because insurance companies wanted to have a way to know how to charge and pay for your health, right? And so for a long time, they wouldn't pay for mental health treatment until they created the DSM. And then they said, oh, okay, you have to classify it. Insurance companies agreed to agree with the DSM, and this is how they can pay out to cover your mental health related costs, right? The ICD-11, same deal. It was created as a socio-political thing to try and address with issues like healthcare costs and things like that. Does that make sense? Get some consensus among physicians and doctors. So you're asking, what are the problems with that? Well, the problems with that is that it's a symptom. It'd be best to diagnose everything in terms of its cause, right? Knowing the cause and effect of all these things would allow for a more definitive diagnosis. We just don't have that. We don't really understand the cause of anything except for strep throat, basically. Yeah, go ahead.
What specifically would you say would be your shortfall, the knowledge you have as a clinical psychologist?
I have minimal. I have the same that you all have. I mean, maybe a little bit more, but you talked about placebo effects, and it's important. People that have mild to moderate mental health issues often benefit significantly from talking to a friend or talking to anybody who's willing to listen to them. And so it's always important to offer somebody an ear and that stuff thing. And does that mean that you're an expert on it? No, you should recognize that you're not an expert. And if they are distressing to you, you should recommend them to some service, right? See a doctor, do something like that. But we all should appreciate that this is one of the big advantage points of having a friend or a significant other or a teacher, is that you can come and talk to them and they'll try to guide you in one way or the other. And you can't stop people from doing that, right? Because I think sometimes that's more harmful than just sitting and listening. Does that answer your question? Is that what you were trying to get at all along? Yeah, so what do I know? I'm a biopsychologist. I chose to study rats instead of humans. That should tell you a little bit about my attitude about humans, right? Don't like them, just in general. No, I'm kidding, right? You guys are okay. Other people, no. In any event, so no, I don't know a whole lot. I mean, I know what I know for myself and my family and those sorts of things. So I think that's similar to your database, or will be when you get to be my age, right? Okay. Yeah, and I'm not implying that I can provide therapy to anybody. Not even in substance abuse, which is my area of expertise, right? Okay. So, but let's talk about what we know about anxiety. So anxiety is a state of fear. It's a state of worry, which would be really what we mean by anxiety, the term. It's a state of avoidance of objects and events. And so when we think about anxiety disorders, we have to think about what is the object on which the fear and the anxiety and the avoidance is on, or the event. And presumably the causal factor may be this fear, right, or towards that event, or the worry that event occurs. And there are differences between fear and anxiety. So fear often induces immobilization and avoidance, whereas anxiety can also include approach, but often a lot of kind of erratic behavior towards approach. So there are clear differences between diagnosing fear and anxiety. But overall, anxiety disorders seem to have their basis in one of these three things. There are many categories of anxiety, and it turns out that we thought these were all anxiety, but some of them are very different. Yeah? Oh, he wants to know how I would differentiate anxiety and stress. Well, stress can be acute or prolonged stress. Stress would be thought of as a causal factor as opposed to anxiety, which is a symptomatic state. Does that make sense? But, when you induce fear and anxiety, you induce stress at the same time. So any kind of strong emotion is a stressor of sorts. Stress is not a particularly useful term when you start talking about these things. That makes sense? Okay, so look, I have to tell you, there are these 5 categories of anxiety, to name the most common. They include phobias, panic disorders, general anxiety disorder. And when you guys the questions you're asking me about is this, general anxiety disorders, where you just feel anxious kind of all the time, and you're unhappy and uncomfortable, and it's sort of continuous, right? In contrast, phobias are directed towards really specific objects, almost always an object that you are very unlikely to come in contact with, because how smart are you? You've put your phobia someplace you can't get to, like I have terrified of sharks. I think I'd never live on the coast. I don't like sharks. Why? Because I grew up in an environment where sharks were very scary. I saw people fall into a shark-infested water and stuff like that and then not ever appear again. So, I have had those experiences in life. I don't like sharks. Even when I go water skiing in Lake Erie, I think, don't fall, there might be a shark. And I think, oh, how silly. Can't possibly be a shark, right? But that kind of defines kind of a mild to moderate phobia that you might have. And phobias can be very extreme, right, and make you very ill if you have to address that particular event. But most of the time what happens is you just generate a lot of anxiety that's a little bit milder to help you avoid ever bumping into that object. Panic disorders, on the other hand, are often unannounced, and they just set in. You start sweating bullets. You have trouble breathing. You feel extremely anxious, like you're about to die. And this can last from 20 minutes to several hours, and then it'll be done until the next time it happens. And so people with panic disorders sort of vary in terms of how often they have the panic disorders. In some cases, they are linked to phobias. Like if you actually run into the phobia, then you have a panic response, right? But they can also exist kind of by themselves. And often we have social panic disorders that are related to how many people were around, etc. Let me just run through the rest of these. You're also probably familiar with obsessive compulsive disorder and post-traumatic stress disorder. These are also forms of anxiety. And so all of these share a lot of similar symptoms, but I can tell you that the etiology, the cause of each of these things is quite different. So the cause of post-traumatic stress disorder appears to be very different from phobias, panics, and general anxiety disorder, similarly with OCD. We'll stop here. We'll pick it up on Friday. So sorry for the confusion at the front end, but make sure to take a look at the first few slides that I post. We have some data on it. Okay? Oh, and have fun doing your IAT. I should have it up in, about 20 minutes. I'll figure out why it's not posting.